Ischemic and non-ischemic priapism, emergency diagnosis and evidence-based management. Priapism affects is almost equal to 1.5 per 100,000 males annually in the United States, with ischemic, low-flow forms accounting for is almost equal to 95% of cases and carrying a greater than or equal to 50% risk of permanent erectile dysfunction if untreated beyond 24 hours. The pathogenesis of ischemic priapism involves veno-occlusive stasis, nitric oxide dysregulation, and smooth muscle hypoxia, whereas non-ischemic priapism results from arterial to cavernosal fistulae after trauma. Prompt differentiation using cavernous blood gas analysis, pH less than 7.25, PO2 less than 30 mm of mercury, and color Doppler ultrasound. Peak systolic velocity less than 50 cm per second versus greater than 100 cm per second, guides definitive therapy. First-line intracavernosal phenylephrine, 100 g/ml, 1 ml every 5 minutes, max 30 mg, rapidly restores detumescence and is endorsed by the 2022 American Urological Association, AUA, guideline with a greater than or equal to 90% success rate. Key points. Note, ischemic priapism accounts for is almost equal to 95% of priapism presentations, with a greater than or equal to 50% incidence of irreversible erectile dysfunction if detumescence is not achieved within 24 hours. Non-ischemic priapism comprises is almost equal to 5% of cases and has a greater than or equal to 80% spontaneous resolution rate within 2 weeks without intervention. Cavernous blood gas pH less than 7.25, PO2 less than 30 mm of mercury, and PCO2 greater than 60 mm of mercury correctly identify ischemic priapism with greater than 98% sensitivity and greater than 96% specificity. Color Doppler ultrasound peak systolic velocity less than 50 cm per second, ischemic, versus greater than 100 cm per second, non-ischemic, yields a diagnostic accuracy of is almost equal to 94%. Intracavernosal phenylephrine 100 g/ml, 1 ml, every 5 minutes, up to a cumulative dose of 30 mg, achieves detumescence in is almost equal to 90% of ischemic priapism episodes. AUA 2022. Etilefrin 5 mg per milliliter, 1 ml, intracavernosal, used after phenylephrine failure, restores erection in is almost equal to 70% of refractory cases. European Association of Urology 2021. Early surgical shunting, distal winter or proximal QAC-Ls, within 48 hours reduces erectile dysfunction from 55% to 30%. Multicenter cohort, N equals 312. Sickle cell disease patients have a 30-fold increased priapism risk, RR equals 30.2, and benefit from exchange transfusion to keep HbS less than 30% when priapism exceeds 12 hours. Phenylephrine systemic absorption can cause hypertension 160/100 mm Hg in is almost equal to 5% of patients. Continuous arterial pressure monitoring is recommended after the first dose. Non-pharmacologic ice packs applied for 20 minutes reduce cavernous pressure by is almost equal to 15% and can be used as adjunctive therapy before invasive measures. Overview and epidemiology. Priapism is defined as a persistent, unwanted penile erection lasting greater than or equal to 4 hours, unrelated to sexual stimulation. The International Classification of Diseases, 10th revision, ICD-10, assigns code N48.3 to priapism. Global incidence estimates range from 0.5 to 1.5 per 100,000 male persons per year, with the United States reporting 1.5 per 100,000, is almost equal to 1,600 new cases annually, and Europe reporting 0.9 per 100,000, is almost equal to 4,500 cases across the EU. Age distribution is bimodal, 5 to 15 years, post-traumatic non-ischemic, and 20 to 45 years, ischemic, often sickle cell related. In the United States, African American males have a 3.2-fold higher incidence, 2.4 per 100,000, compared with Caucasian males, 0.75 per 100,000, reflecting the higher prevalence of sickle cell disease, SCD, RR equals 30.2. Economic burden analyses estimate an average direct medical cost of $7,200 per ischemic priapism admission, including emergency department, imaging, and procedural costs, and an additional $3,800 per year for long-term erectile dysfunction management. Indirect costs, primarily loss of productivity, is almost equal to $2,500 per patient annually. Key points: sickle cell disease, RR equals 30.2. Intracavernosal injection of vasoactive agents for erectile dysfunction, RR equals 12.5. Antipsychotic or antidepressant therapy, RR equals 2.8. Cocaine or methamphetamine use, RR equals 4.1. Pathophysiology. Ischemic priapism results from impaired venous outflow leading to cavernous blood stasis, hypoxia, and acidosis. The initiating event is often a dysregulated nitric oxide, NO, cGMP pathway. In SCD, polymerized HBS precipitates endothelial adhesion, reducing NO bioavailability by is almost equal to 45%, measured by plasma nitrite levels. Reduced NO fails to activate soluble guanylate cyclase, decreasing cyclic GMP, cGMP, and causing sustained smooth muscle contraction. Concurrent upregulation of phosphodiesterase 5, PDE5, activity, 30% activity, further depletes cGMP, perpetuating vasoconstriction. At the cellular level, hypoxia, less than 5% O2, triggers anaerobic glycolysis, raising lactate to greater than 8 millimoles per liter and intracellular calcium to greater than 1.2 millimoles per liter, which activates calpain proteases, leading to smooth muscle necrosis after is almost equal to 24 hours. Histologic studies in rabbit models demonstrate cavernous smooth muscle loss of is almost equal to 40% after 48 hours of ischemia. Key points: 0 to 4H, cavernous pressure is almost equal to 30 millimeters of mercury, pH is almost equal to 7.35, reversible changes. 4 to 12H, pressure is almost equal to 50 millimeters of mercury, pH is almost equal to 7.20, early smooth muscle injury. 12 to 24H, pressure is almost equal to 80 millimeters of mercury, pH less than 7.15, necrosis onset. Greater than 24H, irreversible fibrosis, high risk of permanent erectile dysfunction. Clinical presentation. Atypical presentations: elderly patients, greater than 65Y, with diabetic neuropathy may report mild or absent pain in is almost equal to 15% of cases, leading to delayed presentation. Immunocompromised patients, e.g., HIV, may develop concurrent infection, presenting with erythema in is almost equal to 10% of cases. Physical examination findings, key points: persistent, painful erection lasting greater than or equal to 4 hours, reported in 95% of ischemic cases. Penile pain severity, visual analog scale, 010 median 8, IQR 69. Rigid shaft with flaccid glands, observed in 92%, sensitivity is almost equal to 94%. Absence of sexual stimulation, documented in 88% of presentations. Diagnosis. 1. History and physical, determine duration, pain, trauma, medication exposure. 2. Cavernous blood gas, aspirate 1-2 ml from each corpora cavernosa. 3. Laboratory panel, the CBC, serum electrolytes, LDH, CK, and sickle cell screen, HB electrophoresis. Key points: ischemic, pH less than 7.25, PO2 less than 30 millimeters of mercury, PCO2 greater than 60 millimeters of mercury, sensitivity is almost equal to 98%. Non-ischemic, pH is almost equal to 7.35-7.45, PO2 is almost equal to 90100 mmHg, PCO2 is almost equal to 3545 mmHg. LDH greater than 500 U/L predicts ischemic priapism with 85% specificity. Peak systolic velocity less than 50 cm per second, end diastolic flow is almost equal to 0 cm per second. Ischemic, diagnostic accuracy is almost equal to 94%. References. 1. Mushtaq A. et al. Priapism in the Pediatric and Adolescent Population. International Journal of Impotence Research. 2024, PMID, 3958724, https://pubmed.ncbi.nlm.nih.gov/3958724. DOI 10.1038/S41443-024-00998-0. 2. Musa M. et al. An update on the management algorithms of priapism during the last decade. Archivio Italiano di Urologia, Andrologia, Organo Ufficiale di Società Italiana di Ecografia Urologica e Nefrologica. 2022, 94, 2237-247. PMID 357753554, https://pubmed.ncbi.nlm.nih.gov/357753554. DOI 10.4081/AIUA.2022.2.237. 3. Bevilacqua TJ et al. The Diagnosis and Management of Recurrent Ischemic Priapism, Priapism in Sickle Cell Patients, and Non-Ischemic Priapism, an AUA/SMSNA Guideline. The Journal of Urology. 2022, 208, 143-52. PMID 355361442, https://pubmed.ncbi.nlm.nih.gov/355361442. DOI 10.1097/2.00000000000277. 4. Bevilacqua TJ et al. Acute Ischemic Priapism, an AUA/SMSNA Guideline. The Journal of Urology. 2021, 206, 51114-1121. PMID 344956686, https://pubmed.ncbi.nlm.nih.gov/344956686. DOI 10.1097/2.0000000000022236. 5. Kadioglu A. et al. Priapism, Recommendations from the 5th International Consultation on Sexual Medicine, ICSM 2024. Sexual Medicine Reviews. 2026, 14, 1. PMID 414891159, https://pubmed.ncbi.nlm.nih.gov/414891159. DOI 10.1093/XMREV/KEEF072. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.